and it's a pleasure to be here. I've already met some of you this morning, and we've talked all kinds of international global health projects, so I'm really excited to be here. And I was going to say, too, it's not often I get to see Catherine in the U.S. We met in London, we met in New Zealand, and so I love meeting with you all over the world. So my pleasure to be here. So when Catherine asked, like, what kind of topics might I want to talk about to come here for the Global Health Exchange Lecture, I could have picked a couple of different ones. But if you don't know, this week is actual World Suicide Prevention Week, and tomorrow is World Prevention Suicide Day. So I was really thinking that one of my suicide projects might be most helpful. Now, is this dark enough? Do we need to dim a little bit? Are you good? Can you see?
Let's do the next slide.
All right, see an example. That's a disclosure slide, not all that interesting, but I've in the interest of being recorded and all, that I should disclose that I really have no conflict of interest, and that the project that I'm presenting today is on a funded by an intramural program project at Georgia State University. So what I was going to talk to you about today, and I realize we have about maybe 30, 40 minutes, and should be plenty of time for questions, is that I wanted to give you just a very quick, couple of slides overview about suicide prevention research, because talking to Catherine appears to be not a topic that's come up a lot in these meetings. And in particular about the scarcity of information of suicide research in Africa in particular. And then, since we're going to talk about Uganda, I wanted to give you just a quick overview of the country as a whole, and we, of course, have other experts here in the room, too, but really talk about Uganda, where they are currently, and sort of where they're heading, because I think that really speaks to the topic at hand of mental health research. And then I'm going to talk to you quickly about a project that I've led that we call the Kampala Youth Study, and I'm going to present research findings from that, and we're going to talk about youth suicide attempts from youth living in the slums of Kampala. So just so that you're with me. So from a mental health point of view, or from a global public health point of view, suicide is obviously a huge burden, a big problem. It's very difficult to measure the true magnitude of the problem, but the World Health Organization have at least measured that we're talking about a global mortality rate of 16 per 100,000, or at least one death every 40 seconds, and that's, as I believe, an underestimate at best. And we also talk about suicide at death as opposed to suicide attempts. And suicide attempts obviously occur much more frequently than suicide deaths. So it's just important to keep in mind when we talk about suicidal research that we don't only talk about suicide death, we talk about attempts, we talk about ideation and planning and so forth. So there's this range of suicidal behaviors more broadly that is part of the mental health picture here. But it's also important to recognize that suicidal behaviors is a particular problem among youth. And so youth is varying in definitions, but when we talk about, say, 10 to 24-year-olds, it's a big problem. In the U.S., for example, it's the third or second leading cause of death, depending on how we count on the year we're referring to. So anyway, just a quick overview in terms of the burden. And so when we talk about why are people at risk for suicidal behavior and suicidal death, there are obviously a number of risk factors. And typically, most commonly, we come from a psychiatric or a global mental health perspective. But there are obviously biological factors, there's social environmental factors, as well as others linked to life events and life history. And so the interesting point here, and why I'm interested in suicide research, is because there's been an apparent increase in these problems among youth in particular. I'm going to show you a slide in just a moment. But suffice it to say that suicide is a very complex problem, not unlike many of the other injuries topics that we study, and that there are also differences across countries and cultures, but this hasn't been studied as extensively. Actually, cross-national comparisons are pretty scarce. So when we look at this slide, this is from WHO. It goes back a couple of years. But it's one of the few that actually tries to document the extent to which youth suicide behaviors, or the proportion of suicides that are pertaining to youth. So the first pie chart here looks at 1950. There was only 11 countries that were reported in back then. But at that point in time, 40% of suicides were between those 5 and 44 years. Now, if we move forward to the year 2000, with 47 countries reporting, the proportion or the burden is 55% among youth. So this is one of the charts that is often used to talk about the increase in the burden of suicide deaths among youth. Okay? So what do we know about suicide deaths? Well, typically when we talk public health, we usually use mortality data quite often because we're better at counting deaths than we are other topics typically. And if there's any surveillance system in a country, it tends to be that of death data. And in the US, for example, we obviously do a really, really good job of counting our deaths. So this is a map of suicide rates available as of 2011 that WHO put together. And so I'm less interested in looking at where are the suicide rates higher. What I really want to point out here is that for Africa, there are no data. So meaning your country is coded as white, it means no data available. It is that of 2011. So that really just trying to illustrate, you know, the shortage of data, the scarcity of research underway if we talk about suicide deaths in Africa in particular, also in Australasia. So just wanted to point that out. So because of that, and because of some other work that I've done in Africa, I've been particularly interested in suicide and suicidal behaviors more specifically. This chart is from a book chapter that I've not published quite yet, but the WHO also has what they call the Global Student School-Based Health Survey, or the GSHS for short, that they do in conjunction with technical assistance from the CDC. So it's very similar to those youth risk behavior surveys that some of you may be familiar with. And so they've done those surveys in a range of countries. Not all of them collect all the information, not all of them collect information on suicide attempts and ideation. But this chart summarizes, or it shows those countries with a color on it were included in a book chapter we just wrote to look at suicide ideation now. So suicide ideation meaning thinking about suicide, not attempting suicide. And so we looked at these 19 countries, and we just really wanted to document some regional differences, if there were any, in terms of suicide ideation among youth. This was also among youth. And so what we found is that Africa by far had the highest prevalence of suicide ideation among these 14 to 17-year-olds. Much higher than Central and South America, Asia, Eastern Mediterranean, and also higher than the US. And so not a particularly sophisticated analysis, but at least some way to sort of document what the problem may be in a region where this topic is really understudied. So transitioning into why are we talking about Uganda and what might be the context for Uganda more specifically? Well, as we work in global health and the Millennium Goals, etc., there tend to be a couple of different indicators that we're using to mark health. And so there were a couple of ones that circled in just so you can see, for example, life expectancy of birth. I don't have a... hello? Low one. So anyway, so this first column shows the country, and that being Uganda, and then regional average, meaning the countries that in proximity, and then we have a global average. So for example, if we look at life expectancy at birth and look at males and females, it's age 52, which in Uganda is lower than the region, of course much lower than the global average. But for example, under-5 mortality tends to be lower than in the region overall, but much higher than global. When we talk adult mortality rate, it's much higher whether we compare to the region or globally. And also we talk about prevalence of HIV, much, much higher numbers than the region or the global average as a whole. So there are a number of different health issues that are facing Uganda that are pretty good at measuring. And of course, you all know it's a country in Sub-Saharan Africa. I pointed it out there. So one of the reasons why we're also very interested in Uganda is that it's one of the countries that is projected to have the world's highest population growth. Really profound development and in terms of anticipating what the future will look for the country. So it's estimated right now that the population is somewhere between 30-35 million people. But it is estimated here to have a population to about 130 million by 2050. So we're talking like a 5-fold increase. And so you're talking about a country that has limited capacity in meeting the health needs of the country as a whole, or the population as a whole at this current time. So what would this 5-fold increase do, over the next, 20, 30 years? Will be very interesting, in particular infectious diseases as well as chronic diseases. So that leads me to my next sort of segue into street and slum youth. And I'll be first and be very clear here that I still struggle with the term slum youth. It's not one that I've come up with myself, but it's what my collaborators in Kampala prefer that we use. And so when we talk about street and slum youth, again, it's one of those very difficult to measure. How many street and slum youth are there in the world? Well, there's really no way to know exactly. So estimates vary quite broadly from 100 to 300 million. And typically we talk about these youth living in lower and middle income countries, but of course enumeration is really difficult. But what we do know is that these youth who live on the streets or living in the slums face a lot of needs, of course. First, and typically they're living in poverty. They have all kinds of issues regarding food, clothing, shelter insecurity. It's not clear where they're sleeping every night, for example. And of course, they typically lose out on schooling opportunities depending on where they live. And more importantly, then they're immersed in high-risk environments where we talk about not only infectious diseases, but also high-risk sexual behaviors. We're talking alcohol and drug use, victimization, and of course HIV/AIDS in particular. But of course, data on these youth are scarce because it's difficult to measure, it's difficult to get funding to do research on these youth, and of course it tends to be harder to publish these findings because again, how do you sample, how do you get these information, and what are they representative to? So what we did a couple years ago, we did get funds internally from the university to go and do a pilot project in Kampala. And we are working with an NGO called the Uganda Youth Development Link, and you can see sort of one of the signs that they have. Their programs pertain to drug and substance use, child rights protection, HIV/AIDS, adolescent sexual reproductive health, child labor, trafficking, and what they call social research. So they have several sort of priorities that they do. But we were interested for the first time to help them document the health risk behaviors and the needs that the youth who came to their drop-in centers, what they were experiencing. And so in essence what we did was just a simple convenience sample of the youth that came to these drop-in centers, just to really document the need for prevention, for services, some general health promotion knowledge that they already had on board, and also to figure out how to design intervention and how to best intervene and at what point we can do that. And so this is a map of Kampala, and it's really not to show any more than that these drop-in centers that this NGO serves are scattered all across the city, in particularly low SES neighborhoods. So we did this cross-sectional study in May and June of 2011, and we got a convenience sample of 457, so there was no sampling. We just took everybody who walked in the door who was interested after consenting to participate in the study. And we also didn't restrict the age. So they were 14 to 24 years of age. It's a very broad range, talking from sort of adolescent teens into young adulthood. And we got our ethics review board approvals both from the GSU and also from the Uganda National Science Board. And so this is just to kind of illustrate what one of these drop-in centers may look like, because when we say center, it can mean a lot of different things to different people. But many of them were really just like a hole in the wall, or a room maybe not larger than this particular room, where you had people meeting where there could be counseling sessions, there's social workers and peer educators talking to youth about alcohol and drug use, or about getting HIV screening or getting referral. And also many of these, they teach vocational training. And since most of the participants that come to these drop-in centers are women, they tend to focus on hair braiding, for example, as one of the vocational skills for the women. So, in terms of the survey administration, this was really sort of a simple strategy where we did an anonymous paper and pencil type survey that was administered by the peer educators and the social workers that were working for the UDEL, the NGO. We were concerned about the limited literacy levels of the participants, and so really want to make sure that they understood the questionnaire. So we developed a questionnaire based on the GSHS, the WHO cross-sectional survey that I told you about a minute ago, as well as the Youth Risk Behavior Survey. And we wanted to cast a broad net since we hadn't seen any analysis or any data collected from these youth before, so we wanted to ask a range of behaviors. So in addition to demographic characteristics, we asked about family context, alcohol and drug use, suicidal behaviors, sexual behaviors, STDs, and HIV/AIDS. So really cast a broad net. And the survey was, like I said, here there are two of the peer educators practicing the survey on one another. But it really only took about 30 minutes and was done, across the drop-in locations. We had a pretty high participation rate, 91%. The youth were pretty excited about participating. And we had to have some extensive training before we all started, because this was like the first research project that they had ever been involved in. So for this presentation, the research question at hand was really just to document the prevalence and correlates of suicidal ideation and attempt in this population. very straightforward. So just to show in terms of the questions that we asked about ideation, we asked about planning, attempt, and attempt requiring medical help, which is typically how we do it in many of these youth surveys. So ideation, prevalence here pretty high, 31%, and then of course, the prevalence going down for the increased severity. And not to go through this whole list, but just wanted to share with you the range of the factors that we were interested in and potential correlates. I didn't tell you this, but we were sort of informed by a socio-ecological approach, if you will, trying to look at factors both more proximal to the individual as well as their family circumstances and such. So for example, we asked about school attendance. Only 14% of these youth went to school still. And 40% of them had both parents had died. Now again, we didn't ask the context in which they had died or how long ago they had died, but it speaks to the vulnerability of these youth, obviously. Many of them, if you can see here, 63% had been what they reported physically abused by their parents. And this variable is going to prove to be important later in our analysis, and that's the 21% who said that they had experienced neglect because of their parents' alcohol use. And then we asked about their own drug use, drunkenness, whether they have STDs and HIVs. Traded sex was another important variable that we found in some of our other analysis, so 32% reported that. And of course, very high levels of sadness, 75%, loneliness, 82%, and expecting to die early, almost 44%. So that sort of gives you just a quick context in terms of their own mental health and some of the factors surrounding their lives. So, in terms of some of the results, first this one is just the basic prevalence broken down by the different forms of suicidal behaviors and also by boys and girls. So most of the participants to come to the drop-in centers were girls, but we also had some boys. And it's been interesting in some of the analysis that I've done that the boys seem to be worse off in many ways, and I think it's just sort of the stigma of coming to these drop-in centers and getting this kind of help. But so here we see that in terms of running statistical significance, boys and girls different in terms of ideation, but not in terms of planning attempt and attempt requiring medical help. And this is interesting too, because typically when we do analysis of the prevalence of suicidal behaviors among youth elsewhere in other countries, there are typically pretty profound differences between boys and girls. And in this case, we don't see that. And again, it's just simply my speculation that the boys who come to these drop-in centers, which are primarily attended by girls, there's just something that they're worse off than the girls are. But that's my speculation. So in terms of the logistic regression that we did, so the first one, we are modeling suicide ideation, so whether they were thinking or planning a suicide attempt. And so we have two columns of data here, if you will. We have our bivariate, meaning we have all these variables run independently on suicide ideation, and then we have our adjusted model. So I'll take you through our first one. A little difficult to see perhaps, but they were bolded to highlight significance. So for example, this was significant, showing that girls were more likely than boys to report suicide ideation. Then we see here that being an orphan, a double orphan or two-parent orphan, was significantly associated with ideation, as were parental neglect due to alcohol use. We also found that drug use, drunkenness, STDs and HIV, traded sex, and sadness, loneliness, and expecting to die early all were associated with suicide ideation in these bivariate analysis. But when we plug all those significant variables in, the only thing that remains are being a girl, both parents dead, and also parental neglect due to alcohol use. We have traded sex, and we have sadness, loneliness, and expecting to die early. So a lot of the sort of the mental health / hopelessness, a big driver for suicidal ideation. So it looks very similar, although a little different than suicide attempt. And so we do the same kind of modeling. We plug in the same range of variables. We have fewer things significant here, and I think part of it is because the sample size gets smaller here. Again, remember we started out with a fairly small sample of 457 youth. But parental neglect due to alcohol remains a big important variable. Drug use, drunkenness, STD and HIVs, as well as traded sex, sadness, loneliness, and expecting to die early. Those were significantly associated with suicide attempt in the bivariate analysis. And then when we look at the multivariate one, here is interesting because we have many fewer factors that are important for suicide attempts. And that is parental neglect due to alcohol use, and we have sadness and expecting to die early are really the only one that remains important here. So in terms of the conclusions, we find that the overall prevalence of suicide ideation was very high, 31% in this population. Now we compare it with the GSHS, or the Global Student School-Based Health Survey in Uganda, that was about 22%. So if we were to compare the youth living in the slums with national representative youth in Uganda, their prevalence of suicide ideation much, much higher. And so the key correlates of suicide ideations were being an orphan, parental neglect due to alcohol use, reporting traded sex, sadness, loneliness, and expecting to die early. And it was very similar for suicide attempts in that we have parental neglect due to alcohol use, we have sadness, we have expecting to die early. But the difficulty coming sort of from an hopeful intervention type perspective is very difficult because we know that parental neglect due to alcohol is going to be a very difficult variable to intervene on. So anyway, so we have lots of limitations to this. Of course, we have the issue of generalizability. Like I said, we did a convenience sample of service-seeking youth. So this was not by any stretch, random sampling. We don't know to generalize to what. We're assuming, because we had a fairly large sample, that at least they might be generalizable to other service-seeking youth in a very resource-poor environment. But that remains to be validated. We have a lot of heterogeneity in our sample. So even though all of them were service-seeking and they came to these drop-in centers being very in need of services, all kinds of services, there are very disparate contexts even within them. So we have about 40% of them being orphans, having no longer having their biological mother and father alive. But we had some that were actually living in the slums but living in an intact family. So huge heterogeneity even within. And so how does one address that? How does one speak to that? And then, of course, we have a cross-sectional survey design, which means we can really talk about causality in terms of inferring any sort of meaningful timing in terms of the risk factors and suicidal behaviors. And we also have the issue of possible underreporting, as we know that suicidal behaviors in Uganda, like in many other countries, is full of stigma, meaning that there's a natural hesitation in talking about this. We think it might have been mediated by the fact that they talk to these counselors, these peer workers, peer educators and social workers about a lot of their issues in their lives, that they may not be underreporting as much. But on the other hand, this research setting and doing the cross-sectional surveys that we did was a little different than their day-to-day. So it's very difficult for us to sort of estimate the impact that had on these findings. But in terms of the implications, again, to remind ourselves, this is a pilot project, but we feel compelled to sort of what should the next steps be and what might the implications be. So first of all, we feel that the findings, because they're so high, the mental health needs are so grave, and they're very clearly unmet needs in this population, that needs to be noted in and of itself. There's a clear need for some action regarding mental health needs. And it may be that we need to adopt evidence-based strategies elsewhere for these settings. Now, it's unclear when we talk about existing evidence how they may be adopted and implemented in a setting like this. There's several resources and strategies delivered in schools, but schools operate very, very differently than these drop-in centers. So it's very unclear how to do that. There's been some written work, especially in Uganda. We're talking about involving lay workers and training clinicians, to sort of tackle these problems from a different point of view. But by no means do these have access to sort of hospital-type care and more kind of long-term treatment. So the question is, how do we broaden the access to care, if you will, and get the care into the community where these youth are? And they might be difficult to find through any other mechanism than these type of drop-in centers. And of course, in terms of the social isolation that these youth experience, I mean, the level of loneliness, sadness, hopelessness about the future is really, really grim. And I can't help to think about there are other health concerns too. Now, we focus this whole presentation on just suicide ideation and attempt, but they have fairly high levels of HIV. About 8% of them report current knowledge of having HIV. They have high levels of violence. They have high levels of other health needs. They also drink a lot of alcohol, for example. So I can't help to think that with this social isolation and feeling that they're not going to be around for a long time, they're going to have a shorter life expectancy, that it might be more difficult to reach them. And so by the time we do a cross-sectional survey like this, it's almost too late. It's almost like they've given up. And so at what point do you reach them? At what point do you sort of seek intervention to kind of get them back on track? And have to show you this. And so when I was there, we walked around the drop-in centers and talked to them about the strategies that they use, referring for treatment, et cetera, as they can. And of course, their version of treatment is very different. I mean, it's very short-term. It's very sort of being delivered by lay workers. But I saw this sign on the door as a way to encourage help-seeking. So if you can see it, it's a little blurry. It says, "Do not die in silence. Come, we chat it out." And so we don't have any numbers on the suicide deaths and how many of them die. But a sign like this on the wall, is one of their strategies. We're trying to, prompt the youth to come and talk to them. It's like, do not die in silence. Come, we chat it out. Like, we're here to provide the services they need. So, very sad. But in terms of the future research and what we're planning to do, we are really looking into strategies where if there are ways that we can adopt strategies implemented elsewhere, and how far we can sort of train lay workers in terms of what services can they actually deliver. There's a huge shortage of psychiatrists, nurses, psychologists, and social workers, and so how do we reach these youth with what we have available? And the other big issue is to address the ideal timing for prevention and intervention, given the scarce resources and also given the very high levels of hopelessness and sadness. We need to intervene much sooner. So we actually have published this one, if you're interested in it. We have published a couple other pieces, but we're writing papers on all kinds of things. We're working right now on alcohol and HIV and condom use, particularly in this population, is another important topic that needs to be addressed. Alcohol is another huge problem. But I'll close it there and take questions.
With the limitations in education, how do you get sort of the message out? Is this primarily by word of mouth that they're learning about the centers? And it's just having to sign up if you have a limited literacy in the population?
No, so it's a very good question. So the question is really, how do the youth know about the drop-in centers and how do they know how to get help? And I think it's a very, very good question. And I think it is really just by word of mouth. It's not like this group advertises. I mean, it's not like how would you reach, the audience that you need to get there. So it's really just word of mouth. And I was just talking to a colleague of mine at GSU last week about the whole health literacy. How do you work with people who are very limited, reading and writing skills, and not only how do you reach them, but how do you work with them? It's not like you can give them pamphlets and say, hey, read up on this. It just doesn't work that way. And so I still haven't figured that out, and I still also haven't figured out, how the word of mouth kind of works. I mean, the sort of avalanche technique. I know that this drop-in center, I didn't tell you that, they see about 650 kids a month. Not always the same kids, so kids kind of rotate in and out, which is also interesting. We're trying to do, we're writing a proposal for a longitudinal study right now, and the difficulty that I have is to reassure NIH that I will get the kids to come back and stay in the sample. And how do you do this with a very transient population with this many needs? And so if any of you have ideas about that, I'll be eager to learn. But no, very good question. I don't have a better answer for that.
Great answer. I guess the other question I had was, have you noticed any ways that you can encourage the male population to also seek services?
No, that I haven't noticed. I've had a chat with a gentleman, the executive director who runs the NGO, a little bit, because we were so surprised that about 2/3 of the folks that participate in the study and that come to the centers are women. And in terms of what the needs are for the men or the boys, why are they not coming and why is it? And I don't know if it's because the vocational training offered through most of this is the hair braiding, so by now it's sort of by default the women were more drawn to it. Maybe the boys felt a little more left out. I don't know. And it might be too that The women might have a little bit more flexibility in their days. Many of them who work at all, tend to do domestic work, babysitting and that kind of thing, and so maybe they have a little bit more flexibility. I think the boys, when they do the work, tend to be more hard labor, maybe more monitored in another way. But this is, again, just me speculating. I have no numbers and sort of no way to support that. But I wonder what's up with the boys, because I know the boys need help too. And typically when we talk about homeless youth, we talk about boys in particular because they have a hard time, finding that extended family network, or because they're not doing the domestic work.
I was curious because you had it seemed like a pretty high number, I think, for the apprenticeship skills. Some in the 50s. So I was wondering also what, beyond the hair braiding.
So good question. So some of the drop-in centers have all kinds of vocational training, and there's one or two centers in particular that even have, we're talking like welding and computers and sort of much more hardcore, like you need a lot of equipment. Like the hair braiding is lovely because it's very portable. You need very little skills. I mean, you need skills, but you don't need a lot of materials to kind of make it happen. But of course, with the welding and the computers, they also have things like cooking classes, and they have there's some other sort of more domestic programs. But many of the other ones are targeting for males. I mean, they're trying to encourage the girls to take part of that too, but it's very gender segregated. But so the boys come in and can get a really good sort of applied experience and skills that they can take elsewhere to get a job. But again, very segregated still. So, yes.
So in a very nice talk, you mentioned about it seems a very complex issue, how we're going to address. If you have to say, okay, what's the first priority that we need to address? And based on the numbers that you show, it sounds like that we really need to focus on the parents as well, the fact that they are being using all this alcohol. So have you thought about projects that will, besides focus on the young people, also will address the adults as well, so trying to make those numbers going down?
So a couple of thoughts that will come to my mind. One that we didn't talk at all about is, the levels of alcohol use in Uganda, which is interesting. I didn't give you the context there, but that's why I'm so intrigued by that measure that, parental neglect due to alcohol use. We often don't talk about Uganda and their very high levels of alcohol use. WHO actually estimates that Uganda has one of the highest per capita consumption levels of alcohol in the world. That's not something that most of us have heard of. But they not only do they import a lot of alcohol in Uganda, they also have a lot of alcohol produced within the country, but they don't export it. So a lot of alcohol is consumed there. And you also have a huge proportion of the population that are abstainers, meaning they don't drink at all, meaning that those who drink tend to drink a lot. So, the alcohol piece, I think, is huge. And I think it's so cross-cutting, whether we talk about HIV, we talk about injuries, we talk about suicide, or we talk about, just raising children, or maternal and child health. I mean, I think that's cross-cutting. So that's one of the projects that I'm feeling very compelled about moving forward. The other piece, and I would have never said this a couple of years ago, but the whole issue of maternal child health, reproductive health is huge. I don't have the official numbers on this, but I heard lots of estimates about each Ugandan woman having about 8 children. And so we take that into context of that huge population growth that we're expected to see in the next couple of decades. How will we ever sort of get on track if we don't have female reproductive rights? And again, that's not my area of research at all, but when I'm there, and again, didn't show you a picture of that, but how many of the girls who come to the drop-in centers bring their own little babies with them. And so again, so these, so we're talking about the generational issues. Maybe it's about teaching parenting skills and providing resources for them to be the parents they need to be so that their children are better off. There's a lot of, we have a lot of, in the U.S., a lot of parent interventions that have been very successful in terms of improving outcomes for children. But I think the reproductive health is a huge issue, and that also speaks to the sexual violence, HIV, and other issues. When we were there this summer, there was a big debate about condom shortage. I have tried to find numbers on that too, but haven't. So I don't know what the latest is on that. But again, so when they're trying, it's really difficult because of the expense and availability. I'll say condoms for both contraception and for STD prevention. So no, so alcohol and sex and reproductive health, I think, would be, if I had to pick sort of 2 areas that I think are cross-cutting, that could really have a huge level of impact across domains. So, but that's hard for me to say. So, yes.
Hi, thanks for your talk. So there's so many things, even just the first 2 questions raised, but just to make a comment, the reproductive rate in Uganda has really been a very stubborn challenge. It's been a dilemma that no one can figure out what to do about that, how to sort of address that. Uganda is a very unique place for having such a high rate, 7 or 8 now, of per women. Why is that? You know, what are the cultural issues behind that? One of the very interesting comments that some researchers have pointed to is that there isn't really a huge issue with food in Uganda, because banana trees grow by themselves. Right? We have some folks who know all about banana trees. So nutrition, a lot of people aren't super well nourished. The issue of nutrition is one that isn't a big challenge. So that could be part of just the richness of the soil of Uganda. And also that we expect to see a drop in reproductive rates for women who are educated, but we don't see that to the degree that we would expect to see that in Uganda. So there's some other issues. Anyway, I had 2 questions. I wanted to get back to your data. You mentioned that you actually had, did you ask about HIV status?
Yes.
So you had self-reported.
Yes, just self-reported.
So what were some of the correlates of, I would be really interested to see if our expectations of the relationship between the HIV status and ideation was held up.
You mean here, in terms of what we have for ideation. So what we did, because of the low numbers, when we started looking at ideation and attempt, so
well,
we looked at
8% isn't so
yeah,
low.
well, usually as an epidemiologist, I tend to work with much larger data sets. So 457 to me is like help. I can't do much stratified analysis. But in terms of STD and HIV, so when we combine it, we talk about 14%, and I think I mentioned earlier that about 8% of them had HIV, or at least they've been told that they had it. Now, we expect that to be an undercount as well, given I don't know how recently that they were tested and so forth, and many of them were obviously very sexually active. They were young adults already. And so it was interesting that in terms of HIV was not correlated with ideation or with suicide attempts in at least the multivariate analysis. And so I was wondering about that, because again, from another perspective and from other research, right, we would expect that that would probably contribute to your, your thought of hopelessness and sadness, and also of course of expecting to die early. But it could very well be that it was all confounded too, that what we were measuring, that hope died, dying early, was really captured the stress and agony of actually being HIV positive.
Or what it could point to, this is what I was hoping was going to come out, because I didn't see that data.
Okay.
Is it really points to the success in Uganda of HIV-AIDS counseling. Because if you already have been tested and you know your results, you've already entered into a counseling relationship, even if it's just that one time. And HIV-AIDS counseling in Uganda is fantastically developed, compared to some of the other countries around it. And they would certainly address right away, giving you your status, about hope. That there's hope, there's treatment, there's ways you can change your life. And so I think that might be something to think about in terms of addressing this interesting issue. Unexpected that the HIV status would not be correlated with ideation. So in a weird way, HIV positive folks, because they've had this experience of counseling, aren't reporting the ideation that you would.
That's very interesting. So I think when we go back, and I hope to do another cross-sectional survey there next year, there's so many more questions, of course, and I think we're going to zero in on the alcohol use and the HIV and the reproductive health issues, because I think those need to be the prongs that we need to work on, and so I need to have some expertise. I'm new in HIV research, and so I really need to think that through and include more collaborators who have more experience with that. And when we were there in June, it was interesting too, because I think the Ministry of Health was talking about the proportion of their budget has been spent so much more on treatment and adherence to treatment as opposed to prevention, which is why I think now we're hearing this unofficial conversations about an increase in the incidence and prevalence of HIV, which would be very, very alarming if that is true.
And then my last question was getting to the validation of the surveys. You were using a WHO.
So we modeled it from the Global Student School-Based Health Survey and the YRBS, and so those questions have been, given across countries all over the world. And so, of course, with Uganda being English as our official language, we maintained the survey in English. So yes, we could really adopt those questions really easily.
You must have had conversations with your colleagues, the cultural terms related to suicide and ideation, and do you have any? You can share with us how confident should we be that you're really measuring what you think you're measuring?
Yeah, I think that's a very good question, and I think You know, for example, some of the research where I've looked at, I've written a lot, especially in the U.S. and Europe and elsewhere, about the link, say, between alcohol use and suicide attempts and suicidal behaviors. That, for some reason, doesn't seem to be as important or strong here. And I also wonder, you know, so there are many layers, not only on how you define suicidal behaviors and how you think about it, the stigma around it, the language around it. And so not really gotten that far with it. There are a couple of researchers in Uganda who has written quite a bit about suicidal behavior, but the language piece and sort of the cultural aspects of that, I don't think is well represented in the literature, so we've not had something really to draw from. But I'm sure that there are layers there in addition to the stigma that I mentioned that really needs to be considered. But I'd be the first one to say I'm sort of at a loss to really know. And maybe having focus groups around it, maybe to help to tease some of it out. Yeah, I don't know how else to address it, but I think it's a very important point. And that would pertain to the violence and some of the other topics that we're talking about as well, especially within the family and partners. So. Any other questions? Well, then we're good, and I think we'll hover for a little bit if there are some other people who want to ask them when we close out, but otherwise, we're good. Thank you so much. It's a pleasure to be here.